True or false? Gout only affects joints. It doesn't cause kidney stones.
Oh, that's false. I wish people understood that this was really a systemic disease. They have jagged edges, they're not smooth, and as they come down through the tube that attaches the kidney to the bladder, that tube is pretty small. And so they'll scrape along the ureter, and if they get stuck.
You gave us great tips for preventive strategies, as well as seeking the right expertise, what medications would be used for acute versus the prevention of further gout flare-ups. Hi everyone, welcome to our channel, which is empowering you and all our patients about the knowledge of prevention. Today, I am excited to have a conversation about gout. Yes, gout, with a very seasoned rheumatologist and a close friend and a colleague, Dr. Pamela Kammen. Thank you, Dr. Kammen, for
Thank you for inviting me.
for sharing amazing insights, which I'm really excited about. We'll usually start with a rapid fire.
Okay.
So you could answer yes, no, or give us a one-liner and break some myths for us. What's the most overlooked trigger for a gout flare?
Probably a meal that is heavy in red meat, seafood, or fructose syrup.
What is this? True or false? Gout only affects joints. It doesn't cause kidney stones.
Oh, that's false.
One food you wish every gout patient would stop eating immediately.
Red meat, that includes not only red meat, as is from a cow, but also pork.
NSAIDs, which are non-steroidal anti-inflammatory drugs like ibuprofen, naproxen, when are they considered as the hero in gout?
For an acute flare.
Acute flare.
Yeah, and so if you, I've always told patients if they even think they're going to have a flare, because a lot of people will have a sense that it's beginning, they get a little pain, or they'll tell me they get a little tingling or something in the joint. If you take an NSAID immediately, you can abort that attack.
Immediately, if they have normal renal function.
Yes, if they have normal renal function. If you don't have normal renal function, then no.
Most common myth about gout you wish more people understood.
I wish people understood that this was really a systemic disease, that it's not just a problem with the joints, that it has issues related to the whole body.
Thank you. So now we're going to get into a deeper dive, everything about gout. And here we go. What is the underlying link between type 2 diabetes, chronic diseases like obesity, hypertension, and insulin resistance, and high or elevated uric acid?
Okay. I think the best thing to do would be just to briefly talk about what uric acid is. So uric acid is a breakdown of purines, and purines are in our DNA. So all animals and even plants have some purines. So it's just a normal metabolite that you see in every living thing. If the uric acid, so the uric acid can go up for a couple of reasons. One is some people just make too much. Once it's in the bloodstream, then it is excreted in the kidneys. So if it's not excreted in the kidneys, then that will also make the levels go up in the blood. And the problem with having an elevated uric acid is that it can deposit itself in tissues, skin, joints, kidneys. So some people have kidney stones, and it is very inflammatory. So it's thought to be more of an inflammatory disease. So that's associated with that increased risk of vascular disease. So what are the issues that can contribute to it? One is obesity. In response to obesity, you get insulin production. Of course, some of those patients then go on to develop diabetes. Elevated insulin may interfere with the ability of the kidney to excrete it.
Excrete uric acid.
To excrete the uric acid. Obesity is associated with hypertension. Hypertension also will affect the kidney function, and so the uric acid may not be excreted. Elevated uric acid levels also affect the function of the pancreas. So there's a clear link between diabetes and gout or hyperuricemia or elevated uric acids and gout.
Yeah, absolutely. So, when I have patients either with insulin resistance pre-diabetes or type 2 diabetes with the most common cause being insulin resistance, most of them, I would say at least 70-75% of them either will have elevated uric acid or will have, gout attacks. So in a patient, the way you were saying, um, the uric acid is affecting multiple organs.
That's
Right.
correct.
And that's why you're referring this as a systemic disease.
That is correct. Yeah.
So if it's not just a musculoskeletal or a joint disease, can you explain how the systemic inflammation is occurring or how it is causing complications?
Okay. So we know from other inflammatory diseases like rheumatoid arthritis or lupus that those patients have an increased risk of vascular disease. So they get more, they get earlier, like coronary artery disease. They are also more prone to osteoporosis. So the inflammation has a lot of negative effects on bone metabolism and on our vascular system.
And what are the common areas of the joints that usually get affected in patients when they're having a gout attack?
Right. So it's usually the joints farther away from the center.
Okay, that's a good way to remember.
Yeah, and that's because the uric acid will crystallize out at lower temperatures.
Okay.
So you don't see it really in like shoulders or neck or spine, but anything kind of beyond the shoulders, elbows, wrists, fingers, knees, ankles, feet. And it can cause not only inflammation in joints, but also the soft tissues too.
And what does soft tissue mean for our viewers?
It would be like along the tendons. So sometimes it will almost look like it's the tissue's infected.
And what's the chronic complication for that you've seen as a rheumatologist in with musculoskeletal presentations of gout?
It can be very destructive. So uric acid, if it begins to accumulate, I mean, if the levels are higher in the blood than in the tissue, it's going to migrate out into the tissue. And it just takes up space. And so as it gets bigger and bigger, it begins to destroy the bone and the which will include part of the joint that's next to it.
Yeah.
So it can be extremely destructive.
Yeah, yeah. And even the pain, like patients when they just call us or if they're having a gout flare, it's debilitating, like the pain when it's an acute gout flare. Yeah, so that's just speaking that there are crystals, they're causing inflammation actively, and that's leading to the intense pain.
Yeah, the body really responds to the as foreign. It really says, you need to get out of here. And so it puts this intense response, like, like goodbye.
Yeah.
But so that it can be very painful.
Yeah. What are certain tests or what is a good clinical examination which helps to get to a diagnosis of gout?
One is the clinical appearance of it. So the joints are involved. Like I said, it's just only not the hips, the shoulders, spine. But it really likes the first toe, the base of the first toe. So it's clinical appearance, the character, because people, when they have gout, they'll usually have intermittent, severe episodes, maybe one joint, two joints. And with time, if it's not treated, it becomes multiple joints. They last a little longer, and it can actually become chronic. So you can use the clinical appearance. You can use the levels of the uric acid in the blood, although sometimes they'll fall during an episode. And then you can get fluid from a joint and look at it under a microscope. And if you see the crystal in a white cell, in that white cell that's responding to it, then you know that's gout.
Okay. Are there any other imaging tests that you would recommend?
X-rays, sometimes it does have a characteristic X-ray appearance. Again, it's just accumulating, taking up space. So it has a particular look to it on an X-ray.
Okay. Any ultrasounds or
yeah, you can
CT
see it on
scans?
ultrasound too.
Okay.
You can see because it is denser, so you can see actually the urate with an ultrasound in a joint.
Sure, but these are not necessary if there is a clinical diagnosis.
No,
Okay,
I mean,
that's insightful. What are the most common triggers that you see when a patient is complaining or has a gout flare?
a rich meal heavy in meat. Alcohol is a big one. Alcohol increases the purine metabolism, so you see the uric acid go up. So alcohol, particularly beer.
Yeah, so more breakdown.
Yeah, you
of the
see more
purines.
breakdown, right? Again, the red meat or seafood giving you a big dose of additional purines on top of, because there's purines in meat too.
Right.
So a meal, dehydration is a big one. Because then the kidney function declines, there's less blood flowing to the kidney. It's not being excreted through the kidney, so the levels go up.
Yeah.
So sometimes it's really not how high the uric acid is that triggers the episode, but big shifts.
Yeah.
So if it suddenly goes up, if it suddenly goes down, then things are trying to move in and out of solution, crystal solution, that's what really trigger an episode.
Yeah. This makes me recollect, like there have been several patients who are really doing well with their, lifestyle interventions or with their diabetes care, and they will go to a steakhouse or they start implementing keto diet for a couple of days.
That will do it.
And lo and behold, I will get a call or a voicemail stating that, can I get my colchicine because I'm having an acute flare? This is such an obvious trigger. Yes.
Right. So any sudden increase, whether it be food or your kidneys aren't working, somebody gave you a drug that interferes with its excretion, that will do it.
Yeah. So the hydrochlorothiazide would be common.
A lot of the diuretics.
Diuretics. Okay. What about we know what's causing the trigger. So what are the best preventive strategies to prevent an acute flare?
One is to avoid those red meat, seafood, alcohol. Losing weight helps.
Yes.
So you'll see a reduction, losing weight. If someone's on a drug that's interfering with its excretion, changing that to something else.
Yeah. What about sugary beverages?
And sugary beverages.
Yeah, those are my pet peeves with all patients. Soda and juices, which are out in the grocery stores.
Right. The fructose will increase the metabolism of purines to uric acid.
Yes. Any other interventions that can help patients lower their uric acid levels if they're getting these episodes periodically?
Those are the main ones. Dietary changes, losing weight, looking at the drugs. Again, you want to avoid dehydration, avoid either fasting, like you said, fasting will do it.
Yeah. So good water intake, a good wholesome meal, balanced meal, which is avoiding the processed foods or avoiding these high protein red meat sources for protein. And I'm asking, if you don't know it, is there any role of turmeric in
Turmeric's an anti-inflammatory. It doesn't hurt. I mean, it's an anti-inflammatory.
Yeah.
And it's been shown to be helpful in other inflammatory diseases like RA that's been looked at in rheumatoid arthritis.
Yeah.
It won't hurt.
It won't hurt, right? Okay, thank you.
That and cherries, believe it or not.
And cherries? Okay.
Cherry juice for some reason.
Okay, like fresh cherry juice?
Yeah, cherry juice helps. That has been shown to help.
Okay, great insight. So turmeric and cherry juice. What are your go-to treatment options during a gout flare, as well as to prevent the long-term
So there's two issues. One is an acute flare, which you treat differently than long-term management of the disease. So the goal of treating the acute flare is to reduce the inflammation, whereas the goal of long-term therapy is to reduce uric acid. So they're really two different things. So the things that you have are the anti-inflammatories, colchicine, which just prevents the response of the white cell to the crystal, or corticosteroids.
Okay. So 3 drugs for acute flare.
True. And the corticosteroids, the cortisone, can be given just as a local injection. So if it's one joint that's particularly bad, you can just treat it locally. Or again, you can treat it with oral prednisone. It's not as desirable, but sometimes you're in that situation, particularly if you have someone with kidney disease and you're limited. You can't use the anti-inflammatories. You can't use the colchicine because it... and so sometimes you are stuck using prednisone because that's all you have. But so the goal is to reduce the inflammation. And like I said, the earlier you do it, the faster it goes away. Once this gout gets going, it will eventually die out. Particularly early on, in say, the first couple episodes, it will always be self-limited. But once it gets going, if you haven't really jumped on it early, these things help, but they work a lot better if you get it before it's...
So I wanted you to just give us, some description and comment about these real uric acid crystals passed through the entire renal tubules or the kidney, and how would you describe these?
Well, number one, these hurt.
These hurt, yes, very painful.
So
don't get these, prevention.
So they're little rocks. They have jagged edges. They're not smooth. And as they come down through the tube that attaches the kidney to the bladder, that tube is pretty small. And so they'll scrape along the ureter, and if they get stuck, the ureter will squeeze and try to move it along. They can occasionally get stuck in the ureter, and that's a bigger deal because if nothing's done, then it injures the kidney behind it, or you can get an infection coming up from the bladder up into the kidney.
So kidney infection or bladder infection.
Actually up in the kidney, right? So they're incredibly painful. The other place where you'll see the urate, you see the uridine stones, or some people have what are called tophi, which are collections which you can see on the skin. And if you, and they like pressure points. So you'll see them on the elbows, or this is a common place, or sometimes it just depends on where they are, sometimes on the feet. And if they're big enough, the skin will thin out over them, and you can see them. They look kind of yellow or white. And if you were to drain it, it's this, looks like shiny toothpaste.
Shiny toothpaste.
It looks like shiny
that's all
toothpaste.
uric acid.
And that's pure uric acid.
Yeah. That's insane, like how we can, how the chemistry in the body, if it goes imbalanced, what it can do.
Yeah, it has to go somewhere, and there are the laws of diffusion and osmosis and all that stuff. And so if it's higher in the serum than in the tissues, it's going to move out into the tissues.
Okay. Are there any medications, treatments available for prevention? Or to lower the uric acid?
So prevention is, again, lifestyle changes. Stay away from red meat. That includes pork, seafood, fructose, sugars. Lose weight because of the effect on blood pressure and insulin resistance. And then otherwise, in changing medications, getting rid of medications that may be interfering with its elimination.
Allopurinol.
And that's the one that most people are put on.
So allopurinol does not treat the acute flare, but it's used for preventing further attacks by breaking down the uric acid.
So, and it's important,
Uh-huh.
as I mentioned before, sometimes it's not how high the uric acid is, but the shifts that are going on. So if it suddenly goes up, if it suddenly goes on, that's when your balance goes out, and all of a
Yeah.
sudden you're making these crystals. It's coming
Yeah.
out of solution. Um,
Is there a
and
level of uric acid that patients should be aware of, the threshold that it should be lower than a particular
6,
number? 6.
right?
This is a very important point
Mhm.
because, many lab ranges will say 7, 7.5 is still in the normal range, but anyone with gout history, most of
Yeah.
the
So
rheumatologists recommend to have it below
right,
6.
long term,
Long term.
right? So you don't want to add one of those drugs that lowers uric acid during an acute episode, because then you're just making it worse.
Right.
Okay. So sometimes I see people who have an acute episode and they're going to the emergency room, and they're telling them to start taking allopurinol or
Yeah.
increase it. You don't want to do that, because that will just make the matters worse, because you're getting more shifts.
Right. Yeah.
The uric acid's going down. There's more the uric acid coming out of the tissues into the serum.
Yeah. Yeah. So at that
So
point, you're actually what you told us, the NSAIDs, corticosteroids,
right.
or
Yeah.
the colchicine.
Right. So you make sure it dies down. You treat the
Mm.
inflammation. You don't want to start anything new until it's really died down. Okay. And then the goal in the long term is to lower uric acid, because with time, that uric acid that's been deposited out in all these tissues will slowly come back, will kind of remove itself from the
Yeah.
tissues and come back into the serum.
Okay. Okay. What's since you're what's an advice that you would give to individuals or patients where they're dealing with chronic diseases, or they don't have chronic diseases but have these episodes of gout and may have a chronic complication, may not have a chronic complication, they're under the care of their primary care or their healthcare professional, what expertise that they can seek in medicine to help with their gout,
Right.
prevention as well as treatment?
Yeah. So if you're not getting anywhere with your primary care doctor, I would suggest that you whoever asks for a referral to a rheumatologist.
Rheumatologist.
Febuxostat.
Yeah.
Yeah.
Can you share? Is that used?
That's a little bit like allopurinol.
Okay.
So it too, it just it interferes with the production of uric acid, so it blocks the enzyme that makes uric acid. So it's used in people who don't respond to allopurinol, meaning their uric acids do not come down.
Despite being on
Uh,
allopurinol.
Yes, device.
Okay.
Yeah.
Okay. So
Yeah.
that's the next
So there's
second
a
line.
rare person who just doesn't seem to work for.
Yeah. Yeah.
May be better in people with kidney disease, although you can certainly use allopurinol in kidney disease. There's been a little bit of concern about it,
Yeah.
and that being an increased risk of intravascular events like heart
Okay.
attacks or strokes or whatever.
Okay, so we'll just keep that allopurinol as the go-to. Okay, if I had to summarize it, what we learned was that gout is a systemic, a metabolic disease, inflammatory disease, and imagine if we have a couple of other inflammatory conditions like insulin resistance, type 2 diabetes, or pre-diabetes. That's a nightmare for the body, for our physical health. And you gave us great tips for preventive strategies, as well as seeking the right expertise, what medications would be used for acute versus the prevention of further gout flare-ups. Before we end our discussion, is there any other last tips or words of wisdom that you would like to share with the audience in regards to this topic?
Right. One is understand why this happens. It will make it easier to follow physicians' recommendations. Diet does play a big role in this, and so avoiding red meats, including pork, seafood and the high fructose drinks or sugars is really important. Again, losing weight and just understand, again, why you're doing what you're doing. It's hard to keep taking a pill. And allopurinol is a long-term treatment because it takes probably about 10 years of sustained high uric acid in the blood before you even see your first episode of gout. Bring that out.
This is amazing because, we easily say that when someone gets diagnosed with type 2 diabetes, you've had this for 5 years and then it manifested on the labs. With gout, you're telling us that it's longer. So 10 years before you actually have an acute attack.
Right. So, right. And so what you often see in people who are compliant, take it, is that with time, I'm talking years, their attacks become less often, less severe, shorter. They kind of die out.
And that's a sign of progress.
That's a sign of progress.
Thank you so much. Yes. So please save your kidneys, please save your joints. You want to be independent physically and internally healthy. And we don't need these rocks in our system. Let them be out in the nature. Thank you so much, Dr.
It's been a pleasure.
For the great insights here. Thank you.
I hope that helps.